Hi, good morning, folks, and welcome to the second lecture of the semester MDSC 2409. Previously, we discussed the concept of respect for autonomy, which is the first of four pillars of medical ethics. And in this short video recorded lecture, we'll be discussing the other two, which are beneficence and non maleficence. As usual, this video recording is just meant to complement the main face-to-face lecture, so I'd encourage you to attend your lectures face-to-face. So let's explore these concepts without further ado, right? So the first concept we'll be talking about is beneficence. And remember, it is as part of your professional ethos, you are now, we didn't discuss it in PEC 1001 last year, because you learned about many characteristics of professionalism then. But one of the qualities that you're expected to have as a professional is to be beneficent to your patient, right? The suffix bene means well in Latin, and it's interpreted as literally trying to always aiming to do good for the patient, and it's not merely limited to treating an illness, right? It encompasses listening to the patient. Sometimes a patient just wants a doctor to talk to about their medical condition, about their prognosis. Sometimes family members want to speak to a doctor, and you might be thinking you might be very busy, or rushed off your feet, you're on call, you have competing demands. But sometimes the patient just wants a doctor to talk to, and that's part of doing good for the patient, right? Sometimes you might have to comfort the patient after breaking bad news to them. Um, Nobody's good at inherently good at breaking bad news, um, but as medical professionals, as part of your training, as part of your job, you can't something you can't avoid. So you might have to end up comforting the patient, staying with them, holding their hand, comforting them, depending on the severity of the bad news that you break to them, right? And sometimes you might be able to, as well as the individual patient, you have to be beneficent to the public as well, right? So you might be expected to do some charity work, um, or sometimes deliver public service lectures along those lines, right? Or it's not just treating the patient. Beneficence encompasses a great many things as well. So it seems pretty straightforward at this point, right? So from a philosophical point of view, under normal circumstances, we are not morally required to benefit persons on all occasions. So we don't have to be beneficent to everybody all the time, right? Even when we are positioned to do so. And much beneficent conduct stems from an ideal, from a very philosophical source. However, there is a concept of specific beneficence, which is applicable to us as medical professionals, right? And the reason that is because specific beneficence usually relates to moral relationships, contracts, or special commitments. And remember your social contract or this unwritten social contract you'll have with the public, right, as professionals. So that is where it ties in with moral relationships slash contracts slash commitments, right? And specific beneficence also is directed at a particular group of people. And in our case, as medical professionals, that group of people is patients, right? So just a reminder, by entering this profession and assuming professional roles and absorbing professional characteristics, we do assume certain obligations as specific beneficence as well. And these are sometimes referred to as duties of care. So in exploring beneficence, it's useful to pose the question, can I be too beneficent? That extends to a brief tie-in with medical paternalism. Remember that medical paternalism is acting for the patient's benefit by intentionally overriding their preferences or actions. So back in the old days, the doctor said, okay, we'll do this, we'll prescribe this medication, and that was the end of the discussion. The patient had no input into the doctor's plan. Um, so in trying to be beneficent, you be careful, you might actually be violating the patient's autonomy, and we saw how important patient autonomy was in the previous lecture, right? So for the Bible readers among us, and indeed for maybe some of the non-Bible readers, you might know about the parable of the Good Samaritan. And in this parable, a Samaritan comes across a Jew who's been badly beaten by brigands. Um, in those days, Samaritans and Jews were always at loggerheads, they were mortal enemies, but despite this, the Samaritan helps the traveler nevertheless, right? So that's the kind of ethos we expect of doctors, right? Regardless of patient's race, gender, sexual orientation, socioeconomic status, you're expected to do good for the patient, right? So just fast forward a few centuries later, and you are a young intern, just some beneficent controversies now. You are a young intern, and a lady collapses in front of you in the mall, complaining of abdominal pain, and you have your sesame knife that your dad gave you um, when you were young, and you're just eager to use it, and you think to yourself, right, I can do an appendicectomy on this lady. I've seen enough appendectomies to do one now. It's obvious that this lady has an appendicectomy. I can do one now and relieve her pain. But really ask yourself, is that beneficence, right? Again, another clinical case, you are the doctor on a long haul flight. I'm sure you have come across this. The captain makes a request over the tannoy on the aircraft for any medical personnel to make themselves known to the cabin crew. Would you raise your hand? Um, you you'd be expected to, right? There's certain, but we discussed this in the lecture and in the tutorial. But under normal circumstances, you'd be expected to, and this is part of being beneficent to the patient as well, to patients as well, to the public, right? Sounds kind of far-fetched, this scenario, but let's say you have developed a death device that will allow you to administer drugs to any patient. And over the course of a few years, you use the machine to euthanize 100 patients with a variety of only terminal illnesses, right? Is this beneficence, right? Euthanasia is a big controversy under the sphere of beneficence. So I mentioned is the scenario wasn't very far-fetched. In your reading, you may have come across the name Dr. Jack Kevorkian. He was dubbed the Doctor of Death, and he was actually a very good engineer, very good with his hands, and he actually built from scratch two euthanasia devices, one to administer intravenous drugs and the other to administer gases. The patients were connected to the machines, and the patients pressed a button and self-administered um, intravenous drugs or gases. And he used over several years, he actually euthanized over 100 patients. And he was eventually caught because with the last patient he euthanized, he pressed the button instead of the patient, right? So it's not so far-fetched. But is that being beneficent? In his mind, I'm sure he thought it was. So we spoke about euthanasia, illegal in some countries, not illegal in some others, right? Um, is that it? But aren't we killing the patient as doctors? How is that being beneficent to the patient? But the flip side is you're relieving suffering. You're doing good. You're actually doing good for the patient by relieving a lot of the terminal illnesses. They're associated with a great deal of pain. Um, you're actually doing intractable pain that is not relieved by normal medications. Aren't you doing good? Aren't you being beneficent by relieving patient suffering? Along similar lines, physician-assisted suicide or death. Um, the physician mixes a cocktail of drugs and gives it to the patient, and the patient then takes that cocktail. Um, Same thing, same issue. Are we not killing the patient? But on the flip side, you're relieving suffering, aren't you? So are we doing good for the patient? 5 to midnight. A lot of controversies around 5 to midnight, where patients have been, for example, somebody diagnosed with Alzheimer's, but they still have all their mental faculties, sorry, but they know eventually down the line, a few years down the line, they will lose their mental capacity and they won't be able to make decisions for themselves. So they want to end their lives now while they still have all their mental faculties intact, right? 5 minutes to midnight. And then research. You might be tempted to think that in this day and age, all research is beneficent, right? And by now, after we've been doing research for so many years, um, how on earth could research not be beneficent? But very, very recently, they've discovered that they've been doing research on the Romani people in Europe, so-called gypsies, for many, many years, and they've been doing this research without their consent. So a lot of research, um, some research that in our current day and age is actually not being beneficent, right? Right. So that was just a brief reinforcement of the concept of beneficence, and we'll move on to non-maleficence now, which has its roots in the Hippocratic Oath. And the quote is, "I will do no harm or injustice to them." So basically, with non-maleficence, we emphasize we do not kill, we do not cause pain or suffering, we do not incapacitate, or do not cause offense to the patient. And you will see this Latin term at some point in your career, primum non nocere, right? So as physicians, we are obliged to meet certain standards of care specific to one's specialty. And if one's professional conduct falls below the standard of a reasonably competent physician, then you have acted negligently and caused the patient harm, right? So you've been maleficent to the patient. And so one of the clinical violations of non-maleficence manifests as medical negligence. And we'll have our entire lecture devoted to medical negligence later on. So seems straightforward enough. Don't kill, don't cause offense, don't incapacitate, don't injure or cause suffering, right? But what happens in this scenario? A 43-year-old male accountant is brought into hospital following paracetamol overdose. He's in liver failure from the overdose and requires an urgent liver transplant. It transpires he took the overdose because he embezzled from the company and he can't face his wife and kids, but he refuses liver transplant. What do we do? How is that non-maleficent by accepting his autonomy and letting him basically pass away from liver failure? How can that be non-maleficent, right? Because we're causing suffering by not doing anything, by respecting his autonomy. We're causing suffering, we're causing pain. So just something to think about, right? Next scenario, and the final scenario, a 43-year-old patient, again, I deliberately chose 43 to emphasize the age, in end stage respiratory failure, asks you, his responsible physician, to take him off the ventilator. What would you do? The patient is suffering, he's quadriplegic, he can't move his arms or legs, he has to be catheterized to pass urine, he's fed by an NG tube, his quality of life is extremely poor, and he wants it to end. But if you take him off the ventilator, aren't you killing him? Aren't you violating one of the concepts of non-maleficence, right? But the flip side is that if you do leave him on the ventilator, you're causing him suffering. Are we being beneficent? So that's, again, medical ethics is all about the tension between the four pillars. So that's where the tension between autonomy and beneficence and non-maleficence comes in. Okay. So thanks for your attention, and I'll see you all for the third lecture in the series of medical ethics for MDSE 2409. Okay, thanks very much. See you all later.